Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. I am Norhan Elamin, Rheumatology resident at the Suez Canal University and the new member in Brento. We will talk about uveitis in JIA, juvenile idiopathic arthritis associated uveitis. First, we will review what is uveitis. Itis means inflammation in uveal tract, the middle portion of the eye, which include iris, ciliary body, choroid. Uveitis can be classified according to the side of inflammation into four types. First, anterior uveitis, where the main side of inflammation, iris and ciliary body. Intermediate uveitis, where the main side of inflammation, varus plana and vitreous. Posterior uveitis, where the main side of inflammation, choroid plus or minus retina. Panuveitis, where the inflammation can occur throughout all layers of uveal tract. Yes, anterior uveitis is the main type of uveitis in JIA. Anterior uveitis can occur either in acute form or chronic form. Acute anterior uveitis usually symptomatic, episodic, unilateral. The children have photophobia, pain, redness. The children screaming, "Why I have a red eye? Why I can't look at the light?" The other form is chronic anterior uveitis, where it is usually asymptomatic and discovered accidentally or present with ocular complication. Why usually we spot on uveitis in JIA? We do so because of three reasons. First, uveitis in JIA is the most common extraarticular manifestation. If we have 100 children suffering JIA, 10 to 20% will suffer chronic anterior uveitis. The prevalence of chronic anterior uveitis differ according to the type of JIA. It highly prevalent in oligoarticular type, polyarticular type with rheumatoid factor negative, rare in systemic JIA and enthesitis related JIA. The second reason, uveitis in JIA characterized by being, yes, it is characterized by being unique. Unique because it doesn't follow the course of arthritis and usually asymptomatic. Uveitis in JIA may be a serious condition, as usually the children asymptomatic may present with ocular complications as cataract, glaucoma, hypotony, posterior synecdoche. Vision loss can occur in 10 to 20% of children, so as it may affect vision, we should have strict schedule for screening for chronic anterior uveitis. 2019 ECR, American College of Rheumatology, put guidelines for uveitis in JIA. These guidelines include three items. First, screening, when and who to screen. Second, monitoring for controlled uveitis. Controlled uveitis, by the way, means inactive uveitis or cells less than grade 1+. Third part, they talk about treatment of active uveitis, how we treat children and adolescents with active uveitis. The first part is screening. Why to screen? Because usually patients with JIA have asymptomatic uveitis. How to screen? We can divide children and adolescents with JIA into two groups: high risk group, low to moderate risk group. High risk group mean oligoarticular type, polyarticular type with rheumatoid factor negative, undifferentiated JIA, psoriatic JIA, which have three main important risk factors. First, ANA positivity, as JIA occur in 30% of JIA with ANA positive. Second, important risk factor, disease duration less than 4 years, as uveitis occur with 90% during the first 4 years of the disease. Age of onset of the disease less than 7 years. We should screen this high risk group every 3 months. If they don't have this risk factor, we screen every 6 to 12 months. Some certain types of JIA we can screen from the start every 6 to 12 months, as systemic JIA, enthesitis related JIA, polyarticular type, rheumatoid factor positive. So we can summarize it. We have two groups. High risk group we screen every 3 months. Low to moderate risk group we screen every 6 to 12 months. Second part, how to monitor patients with controlled uveitis. If we have controlled uveitis, patients with controlled uveitis on stable therapy, we monitor a patient every 3 months. If we change any treatment, we have high risk of failure. Tapering topical steroids, we monitor a patient within 1 month. If we taper systemic therapy, we monitor a patient within 2 months. So we can summarize up this information. as the following. Yes, if patient on stable therapy, we monitor every 3 months. We taper systemic therapy within 2 months. Taper topical steroids, we monitor patient within 1 month. Third part, treatment of active uveitis. We should know that. You should know that and usually remember topical steroids is the first weapon and first line of treatment in anterior uveitis, either active or chronic anterior uveitis. If we need to, if the patient still requiring topical steroids for longer duration, we should put a systemic therapy. If the patient is already on systemic therapy for at least 3 months and we can't taper topical steroids, we should escalate or change this systemic therapy, as it is the cut-off point and threshold to do this something. First, we should take notes on the following: topical steroids. Adding or increasing topical steroids for short term to control inflammation is conditionally recommended over adding systemic steroids. We usually prefer prednisolone acetate 1% because it has high efficacy in uveitis, because it has higher penetration for the cornea. We usually prefer it over difluprednate topical steroids, although it is a super treatment used by ophthalmologists because it has higher risk for topical steroid induced cataract or glaucoma. We have less experience with difluprednate topical drops, so prednisolone acetate is a drug of choice mentioned in the guidelines. Second, when to add systemic therapy. We add systemic therapy in two situations. First, when the patient is still requiring topical steroids for longer duration, so we should add systemic therapy to taper topical steroids. Second situation, when patient is already at systemic therapy for at least 3 months and we can't taper topical steroids, so we should change or escalate the dose or frequency of this systemic therapy. What GMARS or biologic treatment to start. Methotrexate is the first line of systemic treatment. In the systemic treatment of uveitis. Subcutaneous methotrexate is conditionally recommended over oral methotrexate. If methotrexate failed, we can consider monoclonal antibody TNF. Monoclonal TNF antibody is conditionally recommended over etanercept. Usually etanercept, which by trade name Enbrel, not preferred either in young or adults in cases of uveitis. We should consider adalimumab or infliximab. Severe active uveitis, site-threatening uveitis, we don't follow stepwise approach. We start from the beginning with methotrexate and monoclonal antibody TNF. If there is no adequate response to monoclonal TNF with standard dose, we should escalate the dose or frequency of monoclonal TNF to above standard dose. If failed first monoclonal antibody with above standard dose, what we do? We shift to another TNF and is conditionally recommended over shifting to another biologic with different category. If failed methotrexate and two monoclonal antibody TNF at above standard dose, we may consider abatacept tocilizumab as alternative biologic option, or MMF leflunomide cyclosporin as alternative non-biologic options. How to taper the treatment for controlled uveitis. If patient well controlled on topical steroids and systemic therapy, we taper topical steroids first. We should usually remember that when we have active uveitis, we should put topical steroid first, and when we have controlled uveitis, we should taper topical steroid first. So topical steroids is first to add and first to taper. In children and adolescents with JIA and controlled uveitis on systemic therapy alone, we can taper systemic therapy only if we have at least 2 years of well-controlled inactive uveitis. Thank you very much.